oftentimes resisted human rights and human rights tools. But of course, how they're implemented and how they actually function will determine whether or not they advance human rights. And a huge part of that is who participates on these committees, what kinds of recommendations do they make, how progressive are those recommendations, and are they focused on addressing racial justice and advancing racial equity. So having doulas participate, having birth workers participate on these committees, know about the committees, and be able to use the recommendations or hold the committee accountable for producing better recommendations is a really important, I think, next step in the current process that we're in. So today we're going to be discussing those maternal mortality review committees. Latona one of our panelists is going to tell us a little bit more about this in detail, but they're basically a process for reviewing local maternal deaths, collecting better data, and then identifying prevention measures. All of our panelists today serve on an MMRC and are also deeply knowledgeable advocates and birth workers from across the country. So we have a range of different states represented. And in line with our obligations as committee members, we're not going to be discussing any confidential case information, but we'll instead be focusing on the potential policy impact of maternal mortality review committees and the role of doulas, birth workers, and communities of color in general in strengthening this mechanism to promote racial equity, improve the quality of care, and reduce deaths and injuries. So I'm going to start by introducing the panelists. As I read your bio, please somehow indicate who you are. I think we have everyone's faces across the screen, but I'm going to start with Latona Giwa. Latona is a perinatal health advocate, birth doula, registered nurse, and certified lactation consultant, IBCLC, in New Orleans, Louisiana. In 2011, she co-founded Birthmark Doula Collective, Louisiana's largest and the only worker-owned birth worker organization. In 2017, she co-founded the New Orleans Breastfeeding Center, Louisiana's first freestanding breastfeeding clinic. Latona organizes rights and builds community around the intersections of birth justice, racial justice, parenting for liberation, and Black body politics. Latona has served on the Louisiana Pregnancy Associated Mortality Review Committee since 2018. Welcome, Latona. And now we have Carmen Mojica. Carmen is a Black Dominican woman born and raised in the Bronx. She is certified professional midwife, writer, and reproductive justice activist with a particular focus on birth justice. The focus of her work is on the empowerment of women and people of the African diaspora. She utilizes her experience as a midwife to raise awareness on maternal and infant health for women, highlighting the disparities in the healthcare system in the United States for women of color. Carmen is one of the co-creators of Bronx Rebirth and Progress Collective, a group of Black mothers, doulas, and organizers who aim to build alternate solutions outside of the system that protect and honor birthing people in the Bronx and their families. Carmen was a member of the New York City Maternal Mortality Review Committee for 3 years at its inception, which reviews individual cases of maternal death, as well as the New York City and New York State Maternal Mortality Review Advisory Committees, which seek to amplify the impact of the review committee's recommendations. Welcome, Carmen. Am I going too fast? Okay. Dr. Saida Pepra is next. So Dr. Saida is both a licensed clinical psychologist and doula. She specializes in multicultural psychology, trauma, suicide prevention, and maternal mental health. An advocate for human rights in childbirth, Dr. Saida is a member of the Black Women Birthing Justice Collective and a collaborator with the Black Mamas Matter Alliance, promoting research, education, and community-based services to positively transform the birthing experiences of Black families. Dr. Saida is the co-creator and director of the Frontline Doulas Centering the Community programs and a co-coordinator of the Sankofa Birth Workers Collective of the Inland Empire in Southern California. Dr. Saida is the founder and executive director of the nonprofit organization Diversity Uplifts Incorporated, facilitating trainings and programs to foster cross-cultural diversity and inclusion within communities and among the providers who serve them. She has served and continues to serve on the Maternal Mortality Review Committees. She served on the California Maternal Suicide Review Committee from 2018 to 2019 and began serving on the California Maternal Mortality Review in 2020. Welcome, Dr. Saida. And then we have Makina Table. Makina is a full-spectrum doula, public health practitioner, and consultant with more than a decade of experience in sexual and reproductive health and justice, training and evaluation, and strategic programming, both nationally and globally, having spent 3 years in rural southeastern Africa, working and serving in adolescent sexual health, malaria, and HIV/AIDS prevention. She currently works as the manager of learning design for Planned Parenthood Federation of America. Makina earned a bachelor's degree in African American Studies and Chemistry from Howard University and a master's degree in Public Health from George Washington University. In her spare time, Makina enjoys watching documentaries and home renovation shows, spending time with her family, and working as a handmade artist and designer. She is based in the Atlanta area and is a member of the Black Mamas Matter Alliance. Makina is also a member of Georgia's Maternal Mortality Review Committee. So welcome, panelists. We're going to start off with Latona, who's going to help ground our conversation and give us just an overview and some baseline information. So Latona, you were one of the first non-physicians invited to have a seat on Louisiana's review committee, which I think is called the Pregnancy Associated Maternal Mortality Review. You were the first birth doula on the committee, and you're currently still a member. So can you explain for us first just what an MMRC is, why having one in your state was important, and why diverse representation on the committee matters?
Absolutely. Thanks, Pilar, and greetings, everyone. So yes, in Louisiana, our MMRC is a PAMR. So if I say PAMR at any point, that's what I'm referring to. And in our state, and I believe in most states, the MMRC serves to review cases of maternal deaths, those deaths being defined as a death from any cause that happens within 1 year of pregnancy. So from pregnancy until up to a year postpartum. And in reviewing those cases, the goal is to understand the drivers of maternal mortality, complications of pregnancy, and really importantly, to understand disparities in the rates of death and that lead to those deaths. Our PAMR uses data to determine and identify potential interventions at the patient level, provider level, facility level, and system level, as well as the community level. And also importantly, those cases that are reviewed, they are anonymous. And we review them in groups, in clusters of similar types. And it's often about a year or two after the death has occurred that we're reviewing them. In my state of Louisiana, there had been an MMRC before, and it was entirely made up of physicians, of obstetricians primarily. And then the committee had sort of ceased to operate. And a really, really pivotal article in the New York Times that featured Simone Landrum in 2018 and her story, as well as Birthmark Doula Collective, really galvanized a movement in our country to reinstate MMRCs or to create MMRCs, among a number of other really important system changes in Black maternal health. And thanks to Simone's story of the death of her child and her almost death in Louisiana, that committee was reinstated and it was diversified. So for the first time in 2018, our review board is not just physicians, but doulas, social workers, addiction experts, domestic IPV experts, mental health experts. And that is extremely valuable. Again and again, it comes up that the physicians in the room who are very well-intentioned and want to make these changes as well, they can't help but see the cases through the eyes of a physician, and they empathize with and they rationalize the medical decisions that are made, and they see it through a medical model, right? And so the non-medical folks in the room bring a holistic view and critique to the cases. And again, we see ways in which these deaths actually were preventable, right? And ways that these lives could have been saved and can be saved in the future. So generally speaking, having non-physicians on an MRC leads to the identification of how to prevent maternal deaths in the future, and and pulls us away from this belief that is really strong in the medical community that if someone is sick or someone has died, there is a reason for that, and they are the reason, right? And so it's been very, very powerful work that we are doing.
So I just, before we move on, want to mention that Latona is being very gracious, but that article actually featured birthmark doulas, but also her work and the power of her work as well. And I think it was a really important moment for showing how important doulas are in this process of humanizing birth and bringing human rights back into those birthing experiences. So I want to ask you a follow-up question. We have been talking about accountability. Kimberly Seals-Allers in the keynote talked about accountability using, the power of consumers and consumer advocacy, making public reviews. When someone is harmed during a birth experience, whether they die or are mistreated or experience obstetric violence, whatever the harm is, oftentimes the person or the family really wants an acknowledgement of the harm, an individual acknowledgement, and some sort of individual accountability at the level of the institution or the provider. The MMRCs are set up to address accountability, but in a different way. So can you explain for us a little bit about what kinds of accountability these MMRCs can get at and what kinds of accountability they're just not built to do?
Yeah, and thank you, Pilar. And I also would be remiss not to mention Linda Villarosa, who wrote that beautiful article. So thank you. So in medicine, when harm is done, we often use the tool of litigation, right? Which gets towards that level of individual accountability, right? The family who has lost someone might sue the doctor or hospital that caused the harm, and they absolutely have the right to do that. But that often does not lead to any systemic changes. And so the review boards, in an effort to actually be able to look at in detail what is happening, to be able to get information from the physicians or the hospitals involved, they have to promise anonymity. Thank you. And so when we're reviewing those cases, it's often very difficult to get the data that has been gotten, and especially in Louisiana, I don't know about other states, but there are many layers of obstacles to get that information, and hospitals or doctors will try to prevent getting it out there if they think they're going to be sued, right? And so there is this tension between getting the information, having it out in the open so that we can make recommendations, we can make policy changes, we can make provider level changes, and that right that a patient has for, or their family has for, individual accountability, right? And it's something that we've struggled with and are still looking at as a committee, is after the review is over, after we've made our recommendations, what can we do then? On the more individual level, on the provider level, right? I believe that you need as much accountability as support, and those go hand in hand, right? So an example, a pattern we see often is it might have been one physician at the end of the day that made a bad call, but more often you see someone who tried to go to the emergency room 10 times, saw 5 different emergency room teams that all turned her away because they did not believe what she was saying and knew about her body, right? That emergency room is never going to know that that woman then died, right? And so what we potentially have the power to do is look at that system, all the different things that happened in a chain that led to her death, and go back to those facilities and give them that information. And that has been tricky and complicated and takes resources, but I would love to see us digging into that work more.
Thank you. And that, I think, brings up a good point, which is that, these committees many of them are new, right? So maybe in Louisiana it had operated before and then was restarted, but across the country, I think almost, most states at this point have one, but many of them are still in the starting stages, right? Some have been operating for several years. Some are going through kind of their first rounds of review now. And so there is this sort of figuring it out stage that we're kind of in, and the opportunity potentially in the future for that to look different, depending on how these committees operate and what the needs are, and sort of what the appetite is or willingness for feedback and accountability is with the different health system partners. So thank you for grounding us in that information, Latona. I want to go next to Dr. Saida. So, Dr. Saida, you're in California. California is often praised for reducing maternal mortality rates, but the racial disparity gap in California also persists. So can you talk about your engagement on the California Maternal Mortality Review Committee and how your perspective as both a doula and a clinical psychologist informs your work there? How do you leverage both in your membership on the committee?
Thank you. So, one of the things that I think in both of those roles as a doula and as a psychologist is important is that I'm listening to people's stories and I'm listening to their actual experience. And so my focus as a clinician, my focus as a support person is about their experience, and it's not about the agenda of the hospital and somebody else's ethical board's decisions and the standards of care, quote unquote, that somebody has decided are important for people who look like the person I'm working with and who have a history. It's about like, what is their actual experience? And so on the doula side, I really try to center, because, similar to what was said before, the majority of the teams often are medical folks. And so they're centered in the experience and perspective from the hospital setting. They're not thinking about the differences that one could have had if they were in an out of hospital birth experience, right? And so having that perspective as a doula, see situations go down at the hospital and hear them in the cases and just think constantly to myself, if they had a midwife, how would this have been managed? If they had been in a more community support aspect, how would they have been centered in their care differently to be able to engage when challenges came up? And so I give stories about the family's experience. And so when often, we're reading the case and, we're thinking about, okay, so they walked into the hospital on this day. And as was said before, they had been to several other ERs we could see, prior. And the whole narrative is about what happened there. And so I'm like, okay, so thinking about like from the social worker's notes in the hospital record, which most people don't really even care to look at, or it doesn't really come up in discussion. It seems like it's like a secondary thing. But in our team, we have, the coroner's notes, and sometimes a coroner will interview a family member. Like I'm listening for the softer side of it. So what's happening around this person? And like one example is that, there was a case where there was a lot of comorbidities happening with the person, but I saw multiple times in the social worker notes that they had multiple children. They were a single parent. They kept asking about when they could be discharged to go home. And so the narrative was sort of being understood as though this person was not interested in sort of non-compliant with medical care. But I'm hearing from her perspective that she went to the doctor because she was in pain, ended up in the hospital for 3 weeks. I don't know what has happened to her children. I can imagine how disruptive that would be to her life. And she's really thinking about the care of her family, in addition to figuring out how she's going to survive and imagining that whatever it is, I've got to get home to these kids, right? And so we're on the hospital side and on the review, it's like, well, this person asked for themselves to come out the hospital, or this, like give in examples, but what were the other parts? So where's the opportunity there for a whole systems approach to something like this? And to me, the intervention would be to have more social support in a case like that, to have a plan for childcare. If you have families that have children asking immediately when they're brought in and they have to stay, I mean, we need a whole new system. Like it's, some of the challenges that we see in the MMRCs are, that the solution is something that exists outside of what's there. And often from the medical perspective, they're only looking to see, based on the system we have, this is what we could have done. So there was no opportunity for improvement because based in our system, there's nothing that can be done. But okay, outside of the system, we know that. I mean, people are dying. We have high disparity in your system, right? So your system is not sufficient. What else can we do outside of the system? And so I try to bring alternative perspectives from the family experience, from the social side. And then on the psychologist side, I'm wanting people to think of like the psyche of the person that was sitting there, the emotions that might have been going through them in how they were interacting with the case, how anxiety, fear situations could have impacted decisions that they made prior or during scenarios that have come up, just to kind of get it a little bit off of just what happened to their physical body, because a lot of it ends up being more interactive between what their experience was, how people were responding to them, the social cues, the implicit biases, than just at what time did they code and all of those logistics.
Thank you. Carmen, we served together on the New York City Maternal Mortality Review Committee, and I've noticed you play a similar role, right, in pointing out or asking your fellow committee members to think about what was going on in the woman's life, in addition to the things that are, listed on the medical record. So you have experience as a midwife, as a doula, as a mutual aid organizer during the pandemic. You have a lot of frontline experience and understanding what challenges folks in the community are having as they give birth and raise families. And I've seen you leverage that and bring that to the committee. What I want to ask you about is that, our committee has agreed to acknowledge structural racism as a factor in contributing to some of these maternal deaths and preventable deaths, and has tried to address some of the social determinants of health in addition to the medical and clinical factors that Dr. Saida was talking about tend to be kind of, at the forefront of these reviews. So I want to ask you, what are some of the challenges that MMRCs encounter in assessing gaps in both our social safety net and our healthcare systems? And what do MMRCs need in order to be able to do this analysis well?
Thank you. So the challenges very much echo what Dr. Saida was talking about, that the system itself is working exactly the way that it's meant to be working from its inception. So oftentimes one of the many reasons why I actually decided to resign from the MMRC is because I felt like I was sitting in the harm doer's office, right? Being with the Department of Health. And the biggest challenge is that no one wants to take full accountability and nobody wants to be responsible. When we're talking about the social systems that could be put in place, then when I was looking at them when I was on the committee, it was also like, well, I, as a Black woman living in the Bronx, have interfaced with all of these public systems that we're talking about that can support someone, and people also experience harm and violence in the very systems that we're saying should be incorporated once again. So I would hear recommendations that like they should be supported by a social worker, or that there should be more protocols written, or or that we should put more money in community-based organizations. The recommendations fall flat for me because there are still systemic issues that prevent even these support systems from being completely effective. I feel that the only way that a maternal mortality and morbidity review committee can be successful is, one, outside of the purview of the Department of Health, which they themselves across the country are perpetuators of violence as well. So I don't know. I've always been the type of person in my own personal life where I'm like, I'm not going to sit in the house of the person that harmed me to have a conversation about the harm. Like, we're going to pick a neutral space where both of us have leverage, right? So that we can have a conversation. And so although I understand the political bureaucratic reasons for it being housed by the Department of Health, the Department of Health is in many ways has their hands tied to be able to apply the pressure necessary, because they're cool with the institutions that cause violence, right? So for it to be effective, these things would have to be, I don't know if there's a neutral ground for this outside of like maybe like a park, right? Or like a city block, because if it's in a community center, the community is obviously and rightfully so going to color everything that they see through their own experiences, right? And then we're going to have to constantly be at odds with people who believe that there's objectivity when everybody is biased. So that was a challenge, and then and I hope I'm addressing your question properly. One of the challenges for me personally was because like 99% of all of my experience with birth is outside of the hospital. So I'm sitting here watching people argue and doctors talking mess and all this other stuff. And I'm like, why didn't you just leave them alone? Why did you break their water to begin with? Like, why did you induce their labor to begin with? Like, because I know normal physiological birth that is mostly undisturbed. So when I'm at the really towards the end of my time at the committee, I was just like, I don't know that I'm effective, because I'm already angry that people are dying, but now I'm angry that y'all are not practicing actual evidence-based practice in these hospitals, and now I'm watching y'all justify this in front of me, right? And so I found it really also I found one of the challenges for the MRC is to retaining community members, because we are not that removed from the violence, right? Like many, like there's sometimes I wish that I could talk about the specifics of things, but I remember listening to to a couple of the cases and being like, yo, that could have been me, that could have been my sister, that could have been my aunt, that could have been my mom. Or even like when recognizing like a case and knowing that like that case was in the news, and the detachment that medicine and the OBGYN medical establishment has to have to even be able to treat people the way that they do. It's non-existent for people who work in the community. And so then we have to not only talk about what's wrong with the case that we're seeing, but then we have to some way, shape, or form control our emotions while we're talking about it, right? I'm not supposed to be pissed off and get in your face and be full, self with my hands and like, yo, like you wilding out right now. Like you literally just justified somebody dying that looks like me. I'm sitting right here, fam, right? And how I saw many people, I know Pilar, we were on the same committee, but I do remember how many folks that we both know left unceremoniously. And that's the best that I can say to the challenges without talking about the confidential details. The challenge is also that the change is not quick enough. And so you often go to these review committees and you leave frustrated because you just sat for like 8 hours steeped in death. And then you're supposed to go on with the rest of your day like is cute. And then knowing that like I reviewed cases in 2017 and people still dying in New York City. We just had somebody in Queens die unexplained. So it's like, what's the point? Like, how long does it take for these things? So then one of the biggest challenges, and I'll end right here because I don't want to take up everybody's time, is that how do you retain community members when community members are constantly being re-traumatized, not only by listening to the cases, but then having to listen to people be callous and justify the medical system and find no blame whatsoever.
Thank you, Carmen. I think it's important as we have this conversation to acknowledge that in addition to it being, already a very difficult setup to begin with, and that the purpose of the committee, right, is to review maternal deaths. And so you're reviewing the events that led to somebody dying, and which can be incredibly emotional. Oftentimes committees will spend a whole day reviewing multiple people's deaths. Then on top of that, there are people, community members and doulas and Black women on these committees who are not having a good experience, right? Or who are offering recommendations and solutions that are not being taken up. And, the toll that takes to participate. Yes.
Sorry, just real quick to drive the point home what you just said. I started in the committee when I was 4 months pregnant. So then that first committee saw me go from my second trimester until postpartum and beyond. So my entire mothering journey is colored by this committee. Not only is it painful to sit there, but I actually had the experience where I went up to almost 42 weeks, so I was a miserable person already. And I went to go get the non-stress test, right? And when I walked in, one of the doctors that was in the committee was giving me care. And I would have thought, oh, this person recognizes who I am. They know who I am. They proceeded to give me the same shitty care that anybody else that looks like me or had reached 42 weeks, and proceeded to scold me, knowing my credentials and knowing that I'm a midwife, proceeded to make me feel like crap in that room when all I needed was to go into labor, right? And then I had to continue to then go to committee meetings with this person. And I'm, usually I'll air this whole beat out if I need to. But because I'm in a professional space, I didn't. And I'm like, how am I supposed to sit here knowing that I gave birth, and before I gave birth, somebody sitting in this committee violated me? And that no matter how long we've just spent talking about microaggressions and racism, you really turned around and did that to somebody that you recognize. And I was hard to miss because I was wearing a very specific dress code at the time for you to pretend like you didn't know who I was. Not that I need to bring clout or pull rank in an ultrasound, but to just hammer the point and drive the point home that where is this change really happening when the very people who are on the committee not only living this, but concurrently as the committee is going on are being harmed by people in the room who were asked to be on this committee.
Thank you for sharing that, Carmen, and thank you for everything that you've contributed. And I'm so sorry for everything that you've had to endure. I always love having Carmen on the panel and in the conversation because she's willing to say things that make other people uncomfortable. And I think, having served on the committee with you, I think you did that for the committee, that you're a person who always tries to bring balance. And in that committee space, the balance that needs to be brought is oftentimes the dissenting voice and the voice of Black women in the Bronx. And you do that bravely every time. So thank you very much for sharing. I want to go to Makina because Makina has recently joined a maternal mortality review committee. She may be considering leaving at this point. I'm not sure, but she's in Georgia. And Georgia is a place where they've been very, very, I don't know how to say this, but there has not been a and how it operates. And so Makina was able to get a place on the committee, and we wanted to hear a little bit about what that experience was like. How did you get on? What has your experience been like so far? And do you have any advice for anyone else, in particular, especially doulas, who might be interested in joining a committee?
Thank you, Pilar, and hi, everyone. Questions. So, I recently joined the Georgia MMRC earlier this year. So I joined during the pandemic, which And talking to people who have been served in various committees is also a different shift. And like the virtual setup, the enduring literally 9 to 5 meetings of reviewing cases like alone in your home. I think one thing that has stuck out to me about my experience on the committee has been I didn't have any expectations going in. I had heard about a lot of the committees. I knew I had colleagues and fellow comrades in the movement that work on various committees, but it never sounded like a place I wanted to be. So honestly, I never really I was never intentional about learning how they operated. When I was invited to join the committee, I think even as a committee member, they aren't very transparent with how they operate, who's on it. Aside from like the cohort of, I'm guessing there was like a push to increase community members on the committee. So I joined with other doulas and social workers and community birth workers, but there was never any type of relationship building. And I think that alone has been extremely shocking to me. I think that this MMRCs can be spaces, should be spaces of like transformation movement work, like, less, I don't know, protection, maybe, but they aren't. I haven't felt that. And I think a lot of that has been that they lack community for me. You don't know, to Carmen's point, you don't know who you're sitting beside. You don't know the allegiances, the agendas, what someone is doing. All I see is, actually, I don't see your face because most people have their cameras off. So you don't know anything about these people that you're supposed to be working alongside to protect my community members. They might not be in everyone's community. And so I think that that's been something that an unexpected challenge of having to like wrap my mind around. I think it's been the MMRC has been a lesson in like what it means to be, what it means to infiltrate. It's been a lesson in strategy that I didn't necessarily want. It's been a lesson in like prioritizing care. When I realized that, after this first meeting, I've been sad for 2 days. What is going on? That is, I didn't expect to enter into that much trauma. I don't think they care for you as a trauma. And that's been something I've been really vocal about on my MMRC is that we are essentially reviewing, to everyone's point, cases that look like my mom, my sister, my cousin, from across the state. Yet it's like, hey, good morning, 20-minute lunch, see y'all next month. Very careless. And that to me has been the biggest shocker. It's led me to like break silos. I'm finding out, I'm emailing the people that I see on the committee to ask, how are you dealing with this? How are you caring for yourself? And I'm fortunate to have a great community of birth workers, of people that love and support me, that now I know, hey, I got a committee meeting this Friday. I'm going to need a lot of extra, and I know how to prepare and care for myself. But it's still really hard. I think that, and I'm losing track of your questions. Your first question was how I got on it. So how I got on it, I don't know. I think it wasn't because of my effort to get on it. I think that just being and doing the work, it kind of found me. Brianna Lipscomb here, knew more about the MMRCs. Like I said, I wasn't as knowledgeable. And so I think that from being a birth worker in the Atlanta area and having been around a lot of, I'm a birth worker that I'm kind of the opposite department. Most of my births are hospital births. And so that's a different lesson in like navigation. I feel like a lot of times my role is like protecting the families that decide to go into the system, helping them to navigate. Like if you're going to be here, you're going to need somebody to have your back. And I think that because of that, there is a certain level of like comfort and practice in like calling out the system, like understanding that like, no, this isn't how it works. And that particular piece has helped me be more vocal. And I think I'm hoping it's something that has been useful on this committee. But honestly, I probably couldn't tell people how to get on a committee because, like I said, Georgia's secretive. I don't know how I got on the committee. I don't know that I would have ever found out that they were looking for committee members, which is a shame in itself. You know what I'm saying? I think I was just supposed to be there. I was just a voice that was supposed to be a part of the community. And so that's something I try to remind myself of when it get real wild in those committees, is that we're in these rooms for reasons. All of us here, whenever we go into any of these rooms, we're in there for reasons, whether it's to like, you know, be revolutionary and like caring for the other people in that space, caring for the other Black women that are on this committee, people of color that are on this committee, and just trying to remember that, like, at the end of the day, I'm doing this to protect my community. I'm doing this to protect the moms that I have in labor right now. I'm doing this to protect my sister who is pregnant. I'm doing this to protect me for, you know, God willing, when I have to go into these systems and places. And so I think just being that voice has been a motivator for me. And it's hard, and I might quit. You know, it's all the things you ask. It depends on the day. But yes, I hope I answered your question. A little rambly.
Yes, absolutely. So I think, you know, one of the things that all of your comments sort of collectively demonstrate, right, is that when presented with a set of facts or information about an individual's life and their death, that who you have on the committee interpreting what that means really matters and is really going to shape the data, right? So the committee is then going to have to decide, was this death preventable? And Carmen's response, or Dr. Saida's response, or Latona's response, right, is going to be maybe probably different, you know, in their interpretation of what contributed to the death than a white male physician who is looking at it through a medical, you know, a very clinical medical lens. And so, you know, it's going to influence the data. It's also going to influence the recommendations. And I think each of you have also sort of spoken to the difficulty of producing really bold recommendations through these committees. So I think we've hit on some of the challenges already, but I do want to ask, does anybody have a bold recommendation that you have been able to offer in the committee that you're particularly proud of, either, you know, whether or not it actually made it into a final report or not? Have you been able to make any recommendations or see movement in the committee? And because we're running a little bit short on time, and I do want to leave questions for the audience, I want to ask sort of a follow-up too. In making those recommendations, right, the committee, in part, probably problematically, has some credibility with lawmakers and decision makers because it is so physician heavy, right, because it does come from this sort of medical model base. But it has this credibility that can be leveraged with lawmakers. And so we may see, and I think we already are seeing, and we may see in the future, that these maternal mortality review committees are going to be sources of recommendations for lawmakers and other health systems to implement or not. So because there are such limited spaces on these committees, and even more limited for doulas, what would you recommend to the audience here in terms of either holding the committees accountable for producing more bold, racially just recommendations, or for implementing the good recommendations that the fellow doulas are able to get through? So I'll leave that to each of you to respond to however you.
Well, I could start with one of the recommendations that I see already moving forward in California was particularly for the Maternal Suicide Committee. We saw that while most people are maybe going in for, you know, a 6-week visit and getting potentially a postpartum depression screen or some kind of perinatal mental health screen early on, nobody is looking at them 6 months, 8 months, 9, 10. But we saw the majority of deaths in the postpartum period after 6 months. So we recommended at least 12 months of support for the entire pregnant and postpartum experience, including maternal mental health. And we've seen laws come out that have expanded care up to 12 months, both for general maternity care and for maternal mental health screening. And that has been a recommendation that I can see people starting to implement. And then the other thing is that there needs to be, to what has been spoken here, intentionality around caring for the hearts of the committee members, doing vicarious trauma and secondary trauma training, having implicit bias and cultural humility training before you start bring all these folks together from different backgrounds. And while that, because even in the way that you review a case, your implicit biases are going to show up as well. And so we've seen that be implemented as well in California. And then that, of course, those recommendations, working on a lot of the national policy groups with Black Lives Matter Alliance and other folks, we're seeing that be replicated in other places. So definitely happy that that's happening and able to participate myself in doing trainings for that.
I can add, I don't know that I haven't been on long enough to see any type of policy change, but something that like micro changes or even just shifts in energy recently has been around the criminalization of, and like how drug use or marijuana use is addressed in cases and reviewed has been something that's been particularly like standouts to me, because it's been a few cases where, it's the medical system is quick. They need to have a reason. They need to place a blame. Usually they want to place it on the patient. And like being a voice to push back as far, even if it's as small as like, no, this classification should, change to maybe, not a yes. I think that I've found it pushing back against with the fact that there is no data to a lot of, I know your swords, I can use your words, has allowed space for other conversations about how we criminalize, how we are recording this person's experience at their end of their life for the records, for their family, which might impact, so many other after, post-mortal like benefits for their own families, has been a really interesting conversation that has happened over the course of a few meetings. Will it, it's changed the way that the committee works? Will it change the way that the policies work? I don't know, but, I'm taking my wins where I can take them. And at least now I feel like we have started to shift the way that we're classifying things. We're starting to realize that patterns and trends and the way that we classify them haven't been able to accurately capture experiences.
So I will say our PAMR has, perhaps because it had more history to begin with, has made a number of policy recommendations and truly changed policies and practices in Louisiana, though far too slowly. And we're also starting from a very bad place, right? So, but one recommendation that I feel proud of that is very simple is that our PAMR is connected to our perinatal quality collaborative in the state, which is more the implementation side, right? So that's the body that is working with hospitals, working with facilities that provide maternity care to change their practices. And the aims for the Perinatal Quality Collaborative when it was conceived were completely without regard to race, were simply about reducing preventable maternal deaths by a certain percentage, right, in a year. And based on the data and information and experiences we had from California at that time, I was very insistent that there needed to be a parallel aim that was specifically about the shrinking the disparity and the outcomes for Black women specifically, because again and again, we see that we will cheer a reduction in hypertension deaths by 20%. But when you look at what happened to Black women, their data didn't change, right? So that's small. It's another sentence in a document, but it's also huge. So I wanted to lift that up. And then I think in general, alongside what Makina is talking about, I see us, those of us who are the non-physicians on the board, I see us over the course of now 4 years, shifting the percentage of deaths that are considered preventable. And in the beginning, it was a long argument every single time, right? And there are plenty of, we're now up to between 67 and 83% of our reviewed deaths have been considered preventable. I probably voted for 97 of them, but but that lens is shifting, right? And one thing I do like about our committee is we actually review deaths regardless of cause, except for vehicular. And I think it's really useful to look at someone who was murdered by their partner, someone who died by suicide, someone who died by drug overdose, and someone who died in the hospital for medical reasons, supposedly, alongside each other, and stop thinking of them as siloed, because it's social, cultural, systemic factors every time, right? So yeah.
So it's 2:52. We have a few minutes left. Unless you wanted to jump in, I thought we could go to questions from the audience. Is that okay?
That's fine. I don't really have anything to say that hasn't been said in the chat. As much as I believe that we need to be in all spaces, I think if there is any transparency in any of the MRCs that y'all belong to or get invited to try to be strategic for people who have the bandwidth, because I generally see it as a waste of time. And the reason I see it as a waste of time is because we've been saying the same thing like a broken record player for how long already? Why do, like, somebody said it in the chat, like, why are we having this meeting? Like, there's mad books, webinars, the presentations, people, experts. Like, what's the point? And that's why I left. I'm like, what's the point? Like, how long is it going to take for what I said in 2017 to actually materialize? And for people to really, hold people accountable and lose money. Ultimately, at the end of the day, like, at what point do the hospitals or people start losing money so that these things actually change? So I think that if we want to be on these committees, we have to think about who we're sending to be on these committees. And if they have the bandwidth and the support to do so, because I have learned that I'm not the person that you should call to go to professional meetings. I don't know if a lot of you know this, but like, that's not me. Don't ask me to go to no professional meeting where I have to code switch. But let's find the person that is good at this, right? But ultimately, it's like, why do we continue to give our time to spaces that aren't working with a sense of urgency?
Well, no, what you said too, Carmen, it makes me think of, I always think about ways to repurpose other people's systems. Like, if I'm going to be in it, I know what I'm here for. You may think I'm here for what you have me for, but I'm actually here for what I'm here for. So one of the things that I have thought has been really valuable is knowing those. Like, it's one thing to hear on the news, oh, Black women die at this percent of rate, but to actually hear how specifically and to be able to bring that back, like as a doula or as a person that advocates for policy around what we need to know from our community side. So I think one of the benefits of having doulas and community folks that are outside the medical in the committees is that we could take that knowledge back today. Now, the committee can take 10 years, 5 years, 3 years to write the report and then do the implementation and put the funding. But right now, I can tell my whole community doula cohort, like, if this situation happens, this is actually medically concerning. Things that I've never even imagined could kill a person, I've learned in those MMRCs. And because I'm not a medical person, it rings something different to me. Like, it makes me feel like it's so urgent to pass that message that I do that in my own trainings with people. I don't have to give the details of all the people, and we don't even know which hospitals it comes from. But, when you can know locally that there's some local hospitals doing all these shenanigans, these doctors are here right among us, like, this could happen. It changes, I think, the sense of urgency that, like, birth workers could have, and people, even therapists and social workers, like, to the way that we advocate for people to get the support if it is out of hospital, to understand why is everybody saying out of hospital care may be something we should look at. What's happening in the hospital? It's hard because in these old systems, only they know. They have it in this little committee with their crew. They share it with their crew. When they publish it, their crew reads it. Then their crew puts the funding. I mean, we wouldn't know any of these things, I think, if some of us were on it. So it is hard. And I do think you have to be selective. And they need to be way more preparatory with preparing people's hearts and minds, especially from the communities that are going to be reading cases about their sisters and their cousins and their aunties. And I will say on that note, though, one of the things that one of the other in New Mexico, I was, saying to as they're opening up an MMRC and they're about to have a bunch of new BIPOC folks on their team. I was like, let's sit down and have a talk about what this is going to be like before they get in, because nobody did that for me. And I have like some thick skin to what Carmen's note is like, I've had to do a lot of code switching and be in hospital spaces. And I worked in a prison for 6.5 years. I know I have a grit for that in a way that even I was having a hard time. So I was like, I really don't want my sisters who never have to learn about and see about and hear about cases of death to go through that by themselves. So we could also help each other.
Thank you, Dr. Saida. Oh, Latona. Let's do Latona, and then we have one question from FA.
Just real quickly, I echo all of that, and I demanded that I have a partner and we do every other session, which I was initially told that I was not allowed to do, that participants needed to attend every session. But this work is so draining, so heavy. So, I feel it in my body, and I'm on, the verge of tears just talking on this panel about the work, right? And that has been, I think that's part of why I've been able to do it for 4 years, is I have a doula sister and we trade off and then we process. I also refused to sit on the panel when I was pregnant. I won't do that.
Thank you all for sharing the different strategies that you're using. Let's go to FA for one question before we have to leave.
Greetings, all. My question goes back to the connection with MMRC connecting to policies, and how do we divest from a system that is using the same system to create our policies? We're talking about having BIPOC folks on the boards, but we know now, and we've been known, that representation doesn't necessarily mean just politics or just someone who is really educated on political education to begin with. So coming in and say, well, I'm a Black doula, that means that I deserve to be on this panel, when there's immense amount of studying that you need to do about political education of Black folks, specifically Black mothers. And so I find it very uncomfortable to know that policy is being made from a board of people who are killing and harming people, and not the folks who are actually on ground doing the work. We're talking about, well, how can we, I think someone put in the chat, how are we supposed to know what to do in the hospitals without this board, when the evidence-based information is right there, when your midwives are right there? And so it's an excuse to say that you don't know what to do. It's complete intentional and ignoring the deaths and the harm that you're doing on people, when the answer is right there.
Alpha, I don't even have to tell you how much I agree with you, but I think that's why I see this process as disgruntled and unenchanted as I am, and the way that I feel about these systems, why I still believe there is an importance to be able to pick folks that have the knowledge to be able to sit in these positions. Like, I don't want to start naming folks in my community, but I look to certain folks who sit in these meetings who have the tact, the maturity, who are older than me, that are able to sit in these spaces and not fly off the handle. And I think that, like, one thing that we're lacking in is that, yes, we need to get rid of the system. We need to do X, Y, and Z to the system, but we're still in this system, and there are people that still depend on it. So we can't dismantle it just for one blow. And that has become even more pertinent to me becoming a mom. I'm like, I cannot blow this thing up because my child has to go there tomorrow, you know? So I think that if we start to take an approach of like, I look at this as a war. We are at war for our humanity. Who are the generals? Who are the commanders? Who are the foot soldiers? I know, and I've identified I'm a medic. I can't be on the battlefield. But if you bring the folks that are coming off the battlefield to me, I'm able to do that, right? And because we have not learned how to identify that within our community, we cannot uh, leverage the whatever it is that we have. Yeah, these people are the same people harming us, but somebody got to be in that room to tell them about themselves, because then they're gonna be acting a fool by them damn selves, right? So it's like it's not
Exactly.
a I or it's like it's a yes and.
Right.
And to that point, I will add, I don't, I would be remiss to say that I think the MMRC is going to be the solution to any of this. I absolutely do not. And it is a strategy. It is a tactic in the larger war. To Carmen's point, I think that there is no, to that point, there is no one solution. As a doula, as someone who is also on the ground supporting families through these systems, you understand how integrated, how overlap, how dependent all of these, weapons are on one another to create this myriad of violence. Let me control my language. But so I think that having strategy, and I think that that's a growth area we can have as a movement, as a community, is absolutely being more strategic. Making sure nobody goes to battle alone, making sure the medic at the side has the support that they need. That has been a huge growth area here, and I think the more that we can continue to strategize and map out tactics, the more that we can continue to support home birth, midwives. All of these things to me have to happen at the same time, so that we can reduce as much harm as possible to our communities.
Well, y'all have laid it out simple and plain, and I appreciate you all for coming to the space and for sharing your raw truthfulness as it pertains to MMRCs. I too was on the same committee as Carmen, and so know exactly what she speaks of. And as a parent and as someone who does sit in those rooms, believe that it's super important for us to be doing the work concurrently, as was said. You know what I mean? We have to be actively dismantling, but also strategically looking at ways to collectively build resources that are centered in community care frameworks. And we can't do that without being in those spaces, because we also have to think about our privilege. It's a privilege to say I'm going to dismantle something and to remove myself from something, and not have to show up in those spaces. And so that's why I'm always of the meet people where they are, not where you expect them to be. And so in understanding that, we understand that it has to happen in many different ways for us to get to the ultimate goal, which is to center people's humanity. Because abundantly, that's what we're talking about. We're talking about our collective humanity being centered in a way that feels good, that's affirming, where people are seen, they are heard, and they genuinely know that someone cares about them. And so as we continue to do this work, let's just continue to be intentional about making sure that that's at the forefront of it, whether it is being sitting in those rooms, working on legislative policy, doing direct services, either as a midwife, a doula, a L&D nurse, whatever it is the capacity that you work in, to understand that and always continuously challenge ourselves to ask ourselves, how am I showing up in this work? And so that it doesn't become normalized behavior, and we don't just make it routine when we show up in these spaces, because it can easily happen and become that. And so, again, I appreciate all of you for showing up and for being here on this panel. Child, the chat on the YouTube is live. And in here as well. Folks, please, you can head on over to the other sessions that are currently live as well. And I thank you all. Have a great and wonderful afternoon. Peace, peace, peace.